All right, we're back.
Perfect. We're all set and right on time. Just
Wonderful.
it's good. Let's see. Well, I guess I should wait until the clock ticks over right to 6:15 in case there's some late people coming in. I always
Hmm.
notice that there's usually a bigger increase in the number of people right at 6:15. But without further ado, welcome to our July virtual series. We're very lucky to have Ben Rose. He's going to present on TMJ or TMD. We were talking a few months ago about this topic because it's one of those things that will come across your pathway in outpatient clinic sometimes as an offhand comment from patients. It's like, oh, by the way, and so it's nice to have some working knowledge, and some people struggle with this. So we're very fortunate to have Ben, who it's been out for 10 years now, eh? Yeah,
Hmm.
just wait. So that is exciting. So thank you for working hard on this presentation, and I will turn the reins over to you.
Sounds good. Thank you very much, Terry. Yeah, we go back pretty far. I was first introduced to you when I probably in 2015, maybe even 2014, actually, when I was on clinical. So um, it's
Oh,
been
wow.
it's been cool seeing how our paths have intertwined, and ultimately we've ended up
Oh,
same place.
that is it is really neat. Yeah, I've had that with a few people um, in the company and outside. It's neat when you've been around along, and it's interesting because people with common interest paths kind of tend to merge sometimes. So yes,
Hmm.
it's been great.
Yeah. Well, I want to thank everybody for joining, especially in the evening after a long day of work. And if anybody adjusted their schedules to attend this, I really appreciate it. Hoping that I can provide everyone with some kind of tangible content to walk away from this presentation from and feel more comfortable treating the jaw. As Terry mentioned, I'm a managing partner. I have 4 offices that I oversee, 3 in Cambridge and then 1 in Somerville. Collectively, at least I've coined us Camberville. A little bit about my pathway. I went to Northeastern for physical therapy. I did the entry level program, graduated in 2016. I was first introduced to Terry when I was on a clinical at Newton Wellesley Hospital, where folks spoke very highly of you, and you kind of connected with a few people that worked there. And then I went on to work locally in the Boston area for about a year, and then ended up in Cambridge and got connected with the folks at Bay State. Joined the company in 2020 on the early heels of the pandemic, and since then I've just been so fortunate to be part of an incredible organization, as so many of you are. Early on in my career, I distinctly remember it was actually my first job. I was working in a physical therapy office, and I was a little self conscious about having bad breath, so I would chew a lot of gum, and I started to have jaw pain. And then I remembered that I had been hit in the jaw years prior playing basketball. And that was really the beginning of my pathway into treating jaw pain, facial pain. Um, so I, at that point, got really interested and began taking continuing education courses and learning from mentors. Along this time frame, I've also become certified in myofascial trigger point therapy through the Myopain Seminars Group for dry needling, and also have my strength conditioning specialty certification. And I just love treating orthopedics. Um, it's interesting to look back into the history of TMJ. I kind of, laugh. People just like as Terry mentioned, like candidly just throw out like, oh, I got jaw pain, I got TMJ, and I think a lot of people don't really understand, where it comes from, as far as being something that we have been able to treat and have thought about treating. Of course, dentistry has been around for a long time, and it really began in dentistry back in the 1930s, but wasn't really considered a legitimate condition, so to speak, until the late or early 80s. Um, it's kind of you know um, interesting to see that the International Headache Society considers TMD secondary to a headache or a secondary form of headache. And I think in practice we see that there's a lot of crossover. So I don't think that's necessarily wrong. But even though we've been aware of, formally in the medical world, jaw pain dating back to the 1930s, and I'm sure folks have had jaw pain going back to, the original humans. But we didn't really have diagnostic classification criteria or anything until 2012. So I do think that it's something that is becoming more prevalent as far as diagnosis and people seeking out formal treatment. The anatomy is something that we should all be familiar with, but it's worth a run through. Um, Most importantly, I think understanding how these muscles will impact function is the key. And additionally, you'll hear that I'll talk a lot about trigger point referral patterns, because I find that a lot of these folks, are dealing with myofascial pain. So it's really important to understand the trigger point referral patterns. But from a functional standpoint, we have our largest masticatory muscles, the masseter and the temporalis. While the masseter is a powerful and dense muscle, the temporalis is not something to be forgotten about. What I would like to highlight is, I hope you can all see my cursor, is the observation of the fibers of the masseter. So while it runs vertically, you've got kind of two major components of the masseter. I feel like this picture doesn't necessarily do the best job of really delineating out the posterior and anterior fibers. But if you look in here closely, and one thing that I have really recently become more mindful of is the anteriorly angulated fibers, meaning that the masseter, not only does it cause the jaw to close, but it can pull the jaw forward, it can protrude the jaw. And I'll talk about sleep in a little bit, and you'll see how there's a connection there. The temporalis, while I find that it's most hypertrophied along the area near the temple, posterior to the eye, it is a rather large muscle. And oftentimes there will be some dysfunction on the posterior aspect. Diving in deeper are the pterygoids. These are incredibly important muscles from a functional standpoint. And then there's, of course, the connection between the lateral pterygoid and the disc. And I always highlight the importance of the cervical muscles, particularly the sternocleidomastoid, but we also have the muscles that help to open the jaw. These are usually ignored. The digastrics are two muscles right here that can be incredibly important to treat, especially in those who have limited opening. What you don't see very clearly here is fascia, and the role of the deep fascia of the anterior neck is something that is also very important to be mindful of in treatment. I always like to highlight that the TMJ is a load-bearing joint. I remember learning this in gross anatomy and kind of being like, what? That doesn't make sense. But in fact, it does. And the amount of load that we can put upon the temporomandibular joint is rather incredible. If you think about how strong our jaw is, so think about the joint forces. If you're biting into like a gobstopper or something, or like, a really hard cracker, whatever it may be, we create a ton of force, and that force is going to be transferred into the joint. And that's why this, articular disc is so important, and can sometimes, if you think about displacements, there can be so much pressure on tissue that's not designed to have pressure on it. So, quick overview, you have the disc, it sits between the joint surface, it moves with the condyle with opening and closing. It moves a little bit less with the rotational movements of the jaw, but nevertheless, it goes from being in the posterior aspect and moving forward, protruding as we move through maximal opening. The first 10 millimeters, there's not a ton of opening. Not a ton of movement of the disc. However, it increases as we open more. The medial and lateral ligaments are not well defined here, but they are very important to consider when we think about stability of the TMJ. And lastly, the retrodiscal material, which is kind of hiding in the back here, it's highly vascular. It's not designed to tolerate load. However, the disc is the opposite. So, whenever we have a displacement, we're going to be putting pressure on tissue that's not designed to be loaded. The movements of the jaw are fairly straightforward. You have opening, mandibular depression is one way to describe it. Functional depression, functional opening, you'll hear it different ways. 33 to 72 millimeters. Everyone has a different anatomical alignment. It's important to be mindful of the type of face you're dealing with. Some people have smaller mouths, some people have bigger mouths. Someone who's 4'8" and someone who's 6'5" are going to have a different amount of opening. That's why I like to use the 3 finger width test as a way to assess a more like personalized range of motion. Functionally, they say about 40 millimeters, 4 centimeters is what we need, and that's my minimal goal for folks that are limited with range of motion. Protrusion, moving forward and backwards, lateral excursion, side to side. Oftentimes, I'll look at these more from a comparison standpoint. 5 to 7 millimeters sounds great. You're not going to necessarily delineate 1 millimeter versus another unless you have all sorts of measurement tools. I find that people have more motion, and I really look from at side to side more often. For the arthrokinematics, how the joint's moving, is it compressing, rotating, translating, spinning? These are things that we can create with our hands, and it's important to understand how the jaw is moving, particularly as it relates to limited opening or deflections, deviations. Passively, we can distract, we can laterally glide, and during the first 10 millimeters of opening, the first centimeter, that's really like if your tongue is on the roof of your mouth. There's mainly rotation, so we're kind of spinning, and then through the rest of the motion, we're gliding forward. If you were to laterally move, you're going to have more of that motion on one side versus the other. So, for example, if I laterally deviated towards the left, then my right TMJ is going to be protruding. It's going to be spinning initially and then protruding, whereas my left side is going to be rotating more so kind of on that vertical axis. As I noted, the disc, with normal movement, it's going to stay between the condyle and the temporal bone throughout motion. This is a good picture to show the lateral collateral ligament and how it connects the condyle to the disc. In my case, when I was hitting the jaw, my jaw was subluxed to the left, and I believe that I tore that ligament because I've had instability and hypermobility on that side ever since. As we close, the disc should retract, should stay in between the surfaces. The tension of lateral pterygoid can contribute to the disc movement, which is an interesting thing to know. This picture shows really just normal motion of the disc. It's a little funky at first, but you'll see the disc here, the bony surfaces as you're opening. They're just staying in between. Commonly, I find that a lot of people will complain of like literally jaw pain, pain on the side of their face, clicking, popping, locking, catching, frequent complaints, reporting that they have trouble sleeping, clenching and grinding are often symptoms that people report. I do find that there frequently is a specific event while a subset of patients might have an insidious onset. I do find that when I really dive into it with a nice like detailed subjective report, that I can find at least something that was specific in either it happened to their jaw or it was an event in their life that contributed to a spike in their symptoms. Most people don't present, at least in my practice, with an acute onset of jaw pain. I'd say 1 out of every 10 people I treat truly has an acute onset. Most folks that I see, it's chronic in nature. It's been at least a couple months, usually a couple years. It takes a long time for people to get to physical therapy. Even in Cambridge and Somerville, where I work, where there's a highly educated, motivated patient population, people who can effectively navigate the healthcare system, there's still a bit of a struggle to get to see a physical therapist. It's always important to screen for headaches, the connection between the mascatory muscles, referral pattern from the TMJ itself, and also the neck muscles. It's so common for folks to have headaches. There's a really great article that I'm going to cite here that goes into a diagnostic classification for jaw pain. This was in JOSPT. I have it cited at the end. I highly recommend that you get access to it. It really does a wonderful job of breaking down, what to look for. And whenever someone asks me, like, hey, how do I figure out how to treat the jaw? Like, I don't feel comfortable with it. I say, look, you just need to know what you're diagnosing, which bucket it falls into, and from there, it's rather smooth sailing. We've got masticatory muscle disorders. This is myofascial pain associated with the jaw muscles. This can be with normal opening, can be with limited opening. We've got disc displacements. The disc displaces and it reduces, and or it doesn't reduce. And if it doesn't reduce, is there limited opening or is there full opening? The disc displacement without reduction with limited opening is oftentimes going to present, if it's acute, as like a locked jaw. The person says that they can't open their jaw all the way. And then there's arthralgia, aka arthritis, and yes, you've got osteoarthritis, osteoarthrosis, and arthralgia. So just different levels of inflammation of the joint itself. I distinctly remember a patient who was in her 80s who was referred to me with like severe joint OA in her TMJ. And I'll never forget her because she was referred to me for dry needling, and it was like early in my journey with dry needling the jaw, and she was adamant about it. And I was like, I looked at her as if she was like my grandmother, like she looked just like her, and I felt so bad needling her, but it was incredibly helpful. But it's a case where I wasn't necessarily going to make a big change in the the condition of the joint, but I was able to help her symptoms by addressing contributing areas. So when we talk about masticatory muscle disorders, usually it's overuse, overstretching. Overuse is very common. Bruxism, grinding teeth, biting nails, stress clenching, trouble sleeping, and maintaining high tension of the muscles throughout the night. It can be muscle guarding as a result of inflammation. Oftentimes, it can present after a dental operation where someone's been open for a long time and the joint gets inflamed, and then they're clenching, they're having reflexive increase in tone. Sometimes it can be overstretching, which would be kind of like what I was referring to a second ago. These disorders can result in decreased joint range of motion, decreased jaw range of motion, but frequently it's not always the case. And that's one of the somewhat difficult things with treating masticatory muscle disorders, because you want there to be limited opening so that like as you do soft tissue work, you can say, oh, like, yeah, like you're opening better. But it's not always the case. I wanted to highlight poor sleep here. And this is something that I've always been mindful of, right? You hear a lot about sleep if you've got a Whoop or some sort of health tracking device. You see all this stuff about sleep. And what's important to know as it relates to the jaw is that light sleep and deepening sleep, we don't necessarily have a relaxation of our muscles. We don't get into that deep state of paralysis. That deep state of paralysis happens in that N3, that deeper sleep, and in our REM sleep. So for those of you, myself included at times, and a lot of our patients who are coming in complaining of muscular-based jaw pain, and even if it's other types of jaw pain, if they're having trouble getting into deep sleep, if they're waking up frequently throughout the night, they're never getting to a point where their jaw muscles relax. And one of the things, if we go back in time here a little bit and look at the anatomy, is our jaw muscles, when we're upright, they're counter gravity. They're helping to keep our jaw from just dropping to the floor. So they're on at a low level constantly. And then if you add in, clenching, bruxism during the day, and then if you add in poor sleep in clenching at night, you can see how this just compounds, and you have a near constant engagement of these muscles. So I highly recommend with any patient who has TMJ, jaw-based pain, especially those who have more of a muscular-based pain, that you always screen for poor sleep and sleep hygiene and talk with them about the importance of addressing that. I've had a number of patients that I treated for probably far too long, and we were making somewhat good progress, just enough that we were both saying, okay, let's keep doing what we're doing. And I didn't address sleep. And I look back on those patients, and I can guarantee you that there would have been at least a 50% improvement, or just a faster, progress towards where we were at the time if we had addressed sleep. And since diving into this more, I've had so many patients that I've been able to make a much greater impact with less treatment. And oftentimes this might require, screening for apneas and referral to a sleep specialist and doing sleep studies. And of course, that's not within my scope. But what I realize is that when they go and see these people and they improve their sleep, the impact of treatment, it can be, 2-3 times, even more. We talked about these muscles a little bit, so I'm going to move quickly here just to make sure that I have enough time to talk about cases. Trigger point referral patterns are incredibly important. There's a website called triggerpoints.net, or you can just Google them. The referral patterns for the masseter and the temporalis, as you can see here, really just mimic lateral facial pain, but they also refer into the teeth. There's cases of folks who have thought that they had cavities and they've gotten treatment for that and they continue to have pain. Oftentimes those folks might have masticatory muscle disorders. eyebrow pain, ear pain, and then there's also a lot of interesting things like tinnitus, fullness of the ear, ringing, intermittently. A lot of those things are complaints that we'll hear from people who have jaw pain that could be coming from these muscles. Diving in deeper, you've got your pterygoids, interesting referral patterns here into the cheek, right in front of the ear, inside of the mouth, behind the chin, the mandible there. That's a common place. And then when you look at the digastrics, anterior, like front, bottom of the tooth pain is a very common one. So you always kind of have to put two and two together, and you listen to what the patient is telling you, and then you look at them functionally and what their impairments are, and as you're palpating, oftentimes you can kind of piece together that dysfunction in these muscles is a contributing component of their pain. For the disc displacements, it can be microtrauma, it can be macrotrauma. Like in my case, it's not uncommon that a patient tells me they were hit in the face, especially athletes. I do find that microtrauma associated with bruxism is very common. This is the patient who comes in and says, I've had clicking and popping, but I've been clenching and grinding my teeth my whole life, and they show you their mouth, and half of their bottom teeth are eroded from grinding. And those folks, you think about all the compressive forces that I mentioned earlier, that's going to take a toll on the disc, and it can get, kind of due to the pressure, it can, be pushed out of place, for lack of a better way to put it. And that can contribute to these disc displacements. So that's where just listening to the patient's subjective is really important. If they tell you a macro trauma is an easy one, like I was coming down from a rebound and my friend hit me in the jaw, and ever since then I've had a ton of pain, and when I open and close my mouth, it clicks. Pretty straightforward. Oftentimes with the macro traumas, there'll be a limited opening associated with like the period of like high pain. That's usually that inflammatory stage where the retrodiscal tissue is compressed and gets highly irritated. I'll tell you, this can be incredibly painful. My sister recently had a bout of jaw pain. She was out in California, so it's really hard for me to help her. And it took a long time, even with constant intervention of anti-inflammatories and ice and rest. It took about 6 weeks really for her jaw just to calm down. So that's something that you want to screen for when you're asking questions during the subjective. Not just kind of being like, oh, cool, like you had an event, like how about now? Diving into it deeper, the specifics of like, okay, how painful was it and how has it progressed? Gives you a better idea of what happened and what's contributing to where they are now. I kind of alluded to this already, like the retrodiscal material, it's not designed to tolerate load. However, over the course of time, it will redevelop, or remodel is a better way to put it, and it will develop into a tissue that is tolerant of load. I can't necessarily speak to the specifics if that's just that the vascularity is reduced, or if the tissue itself actually like changes its structure. But the takeaway is when you have someone who has a chronic presentation of clicking, if it's not painful, if it's not functionally limiting them, it's not necessarily considered a pathology. And I tell patients, by treating the impairments that you present with, we may see a change in the clicking. It hopefully will reduce in frequency, but I can't guarantee that. What I can guarantee you is that with intervention, we should see an improvement in range of motion, a reduction in your symptoms, and so on and so forth. So definitely something that you want to, lay the foundation on from an education standpoint from day one. A couple more pictures here just to look at, what's happening with these displacements. So in this picture, you can see the white tissue here. The disc is slightly in front, so it's displaced. As the person opens, because of the pressure and the condyle moving forward, it clicks back into place. And then as they go to close, it clicks anteriorly again. It looks a little funny because you might say, oh, well, it's back into place. It's kind of like partially in place. And that's where the click would happen right here. If it doesn't reduce, you can see, the red stuff in the back. The disc is the white stuff in front. It just stays in front the whole time. So if you think about this as an acute displacement, and you've got this pressure on this vascular tissue that's not designed to tolerate load, and you're biting into a bagel, for example, and your pain's on the right side, and you're biting on the left side, you're compressing the opposite side. So you're just getting a lot of pressure on tissue that's irritated. It'd be like walking on a knee that you just sprained, instead of using crutches and deloading it. Arthralgia is fairly straightforward, not super common. I do find that these folks are a little bit more responsive to joint mobilization, which is nice. So really quickly, assessment is fairly straightforward. I start out by educating the patient about anatomy, and then we'll do 5 repetitions of opening and closing. I tell the patient to let me know how many times they experience a click after they're done opening and closing. I always ask them to move slowly. Usually patients, they are very uncomfortable. They're kind of like looking around, like, why are you staring at my jaw? And then they'll just go like this. So not very helpful. So I always tell patients, I want you to move at a cadence of 1, 2, 3, 1, 2, 3. Move slowly. Let me watch your motion. Let me know how it feels. What you're looking for is, as they're opening and closing, are they deviating? Is there a C curve, an S curve? Are they staying towards one side? And then I'll look at, lateral glide. I'll look at protrusion, retraction. I'll also have them bite down and smile so I can see their teeth. I can get a better idea of where their bite is as far as an alignment standpoint. And also just paying attention to the motion, as they're talking, is there any movement side to side? Then I'll go on to do palpation. I'll palpate the joint right in front of the ear, palpate the masseter. I usually educate the patient about the anatomy as I'm doing that, temporalis, and, then going into the neck. You can usually pretty easily figure out where you are when you're palpating. And, I find that when people are hyper irritable, very sensitive, it's very easy to palpate the tissue and get a response from the patient. Oh, that's uncomfortable. A slight blanching of your fingertip, is enough pressure to help you delineate whether or not, the patient is hypersensitive to palpation. And oftentimes you'll be able to know pretty quickly with light pressure, they'll be like, ow, this hurts. With that being said, some people that are more chronic, you may need to push it a little harder. And that doesn't necessarily mean that they're, not in need of soft tissue work. Excuse me. Excuse me. So this is a nice schematic that breaks down the different diagnostic classifications. And I can, this is recorded, so you can always dive into this. You can just reach out to me and I can share it with you. From a treatment standpoint, I'll do a lot of soft tissue work, Graston, dry needling, some mobilization, but it's less frequent, and then a lot of manual therapy to the neck muscles as well, and then postural and motor control training. I'm going to move quickly through this because I want to dive into some cases. Mobilization is something people are uncomfortable with. The good thing is you don't actually have to do it that often. And when you do practice it, it's very comfortable because you can actually grab onto the whole joint, which you can't always do. I mentioned deviations. Oftentimes folks will present with either a C or an S type deviation or deflection, depending on the terminology. A C deviation would mean that as the patient opens, they kind of go to one side and then come back to the middle. And S would mean that they kind of wiggle back and forth. Sometimes it's more of a squiggly line. Sometimes you can associate that with clicking and popping. The patient will say, oh yeah, I just popped, and you'll see it kind of wiggle. Mechanically that makes sense, right? Because it's moving over the disc. C deviations can oftentimes indicate that there's a hypomobility on the side that the jaw deviates towards. It's not always the case, but it's a good starting point from your assessment. When you're from your observation going into your assessment. And S deviation is oftentimes motor control, but as I mentioned, it could also be due to the disc, popping in and out. I like to use a lot of motor control drills to help retrain motion. I like it from a standpoint of awareness of mobility, and then also to help control change that we're making with our manual therapy treatments. We've got on Limber all of these exercises. They're not necessarily perfect, but they're pretty good. And with them, you'll see that we have opening through part of the range of motion, through full range, and movement side to side. And I'll usually change between different degrees of opening and closing. I'm in the South Boston clinic. I think the air is a little dry here, or I'm just talking too much. Excuse me. So I'll usually prescribe these motor control exercises quite frequently. For people who have limited opening, we have a couple different self stretches. I really like this one here. I also like just telling patients to literally grab onto your bottom teeth and pull down. There's a self-mobilization, but it's just not that effective. It's hard to teach patients. Sometimes people do it right. Usually they just end up biting their thumb as they're biting. The motor control exercises and self-massage really are my go-to, and I find them to be very, very helpful. A couple quick clinical pearls. Diagnosis is key. Knowing what you're treating is really just the key to success. As with many other presentations, obviously, when you're able to drill down on it, you are opening up clarity for how to proceed. With the jaw, because there's really, these buckets that the diagnosis falls into, it helps to just give you a framework of what to treat. With masticatory muscle disorders, you're going to primarily focus on the muscles. With a disc displacement, in the acute phase, you're going to work more in anti-inflammatories and motion control and reducing stress on the area. And then as time goes on, you start to work on addressing maybe muscular components, but then also retraining motion. If someone truly is super acute, you want to be gentle. You don't want to over mobilize. It's important to be mindful of the inflammatory component. It's a very small joint, very small space, and if you are increasing load on it too quickly, that can cause problems. Always important to address posture, and the contributing components of the upper cervical spine, forward head posture, all of the neck muscles, oftentimes referring to the head, sometimes in the face as well. So if you're treating the face without treating the neck, then you're not really addressing the whole picture. And it's always important to follow up joint mobilization with motor control training, particularly with dry needling. I find that I frequently will have the patient sit up and then we'll just jump right into motor control drills. Helps them manage some of the discomfort associated with the treatment, but it also is like a prime opportunity to create neurophysiological change and neuromuscular control of an area that just had a potent stimulus. And then lastly, the joint loading is counterintuitive. If I bite down on the right side, I'm loading the left side. And you can use this to your advantage. If someone says, when I chew on the right, I have pain on the left, then that indicates that it's more the joint on the left side is being irritated or overloaded. If someone says, when I chew on the right side, as I continue to chew that piece of pizza, I get pain. And that indicates that you're probably dealing with more of a muscular presentation. So I want to dive into a couple of cases. Terry, how much time do I have?
You're good. We typically go till 7. We can go a little bit after to leave some time for question and answer. But
Okay.
But I think it's important to highlight these cases. So just keep on keeping on. And then if anyone has questions, they can always put them in the chat, and then Ben can address them once he's done or has a good point to address them.
Wonderful. All right. So I wanted to pick out a couple of cases that I'm actually treating now and then see frequently. I've treat in 4 different clinics throughout a major city, and as a result of that, I see different presentations, and it's kind of cool because my office that's in the Porter Square area, our patient population is older, and then our office that's at MIT, they're younger. So I kind of get a nice mix. But with that being said, there's a bit of a funnel towards the most common presentations based on my experience, and that's really starting with masticatory muscle myalgia. And that's one thing that is important to take away from this, is that you don't need to be able to do some crazy mobilization of the TMJ. You don't need to be a rocket scientist. It's fairly straightforward with these folks. If you narrow them into this category, and you're able to figure out the behavioral contributing factors and the modifiable impairments, you can treat them. You could walk away from this presentation today and go treat someone with jaw pain and feel confident that you're treating them correctly. When you throw in headaches, sometimes it can get a little bit more involved just when you're looking at the bigger picture. But a lot of us are very familiar with treating cervicogenic type headache pain. So you kind of utilize your skills from that. Where it can get a little bit more challenging, I think, is chronic disc displacements. And I find that these folks, oftentimes, the reason that it can be more challenging is because there can be a lot going on in that they've got some muscular-based impairments. They have the clicking and popping. They have some limited opening at times. Sometimes they're hypermobile. So you really want to kind of be sequenced in your treatment, treat the impairment that sticks out to you the most, and then work your way towards the things that you're not quite sure about. And I think that confidence oftentimes is a reason that it can be hard to treat this patient population, because they're going to ask you questions like, specifically like the clicking, when will the clicking go away? What can we do to change that? And if you've treated one TMJ patient ever and they say this is your first one, I'm not really sure. But you can take from the start of this presentation the important fact that the clicking doesn't matter. Plain and simple. What matters is what causes you pain and what functionally limits you. And those are the impairments that you want to treat. And if the clicking changes, great, and I hope it does, but that's not the goal of our care. I less frequently see lockjaw. I kind of miss it. It's kind of fun. Arthralgia is not as common. And what I don't have here is post-operative presentations, whether that's like a surgery to the palate. Had a really cool one that was like a patient who was enrolled in a study at Harvard at the dental school, and they did like a very slow and painful expansion of her palate. So they didn't have to actually fracture it, just slow and painful. It was incredible, kind of fun to work with her. Had a patient who got kicked in the face by a horse, so some random things like that, but they're less common. So a good case, this is very common in my practice, a 35-year-old female who presents with chronic history of jaw pain, denies a specific incident, reports pain along the lateral aspect of the face bilaterally. Pain worsens with increased stress and prolonged computer use. They also report poor sleep, trouble falling asleep and staying asleep, and additionally, they have intermittent headaches that increase in frequency when the jaw is more painful. So the question would be, where do we go from here? Well, I always like to dive into some of the specifics. As I mentioned earlier, people oftentimes will deny a specific incident in these cases. I try and dig deep into that and figure out, okay, are you sure there's no specific incident, or was there something that might have happened? Because then sometimes you can kind of put together the story a little bit more, and then that helps me, I find, with communication and education. Also developing a prognosis. And with this, patients not reporting that there's any clicking or popping, so that's nice and simple. So you can basically rule out, you're going to do some palpation assessment, but for the most part, you can say, okay, it's probably not the case that they have a disc displacement. And if they're 35, unless there's been some sort of major event, which the patient states there wasn't, then the chances of it being an arthralgia or some sort of osteoarthritis is very low. So already, even with just a short paragraph of information, you can say this patient probably has a masticatory muscle disorder. What else could it really be? So then you dive into watching them move, and then assessing the musculature. Are you able to recreate the pain with palpation? Are you palpating and finding that there are these massive trigger points in hypertrophied tissues and through the masseters, temporalis? It's usually fairly easy to feel. Now, if someone presents with some sort of deviation, depending on the chronicity of it, you might find that they even have atrophy on one side versus the other. People who have a large deviation and restriction, on the right, for example, and especially if they chew on the right all the time, might have hypertrophy of the right masseter. So things that you can palpate and kind of start to put together the functional pattern with. So from a treatment standpoint, based off of the specifics of what you find, my focus would be, narrowing in on soft tissue intervention for the masticatory muscles, the cervical muscles, upper trap. And then from there, assuming that there's, a deviation or a limitation, we'll then, either address those. And if there's no deviation, no limitation, which sometimes is the case, then you're focusing more on what you're feeling from the muscular standpoint and how you see change in their symptoms over the course of, sequenced appointments. So I don't mean to make this seem like it's I don't want to make this seem like it's confusing. I'm trying to make it simple because it really is simple. Disc displacements can be perhaps a little bit more confusing. This is a good example. A patient is a 40-year-old female who presents with unilateral jaw pain dating back to an intensive dental operation 5 years ago. Patient reports immediately following the dental operation that they had trouble opening their mouth fully. This was accompanied by severe unilateral jaw pain. The patient reports they managed the pain with anti-inflammatory meds, rest, and avoiding painful movements. The pain resolved over the following 2 weeks, but there has been a clicking on the side ever since. Patient reports currently they continue to have pain on that side, worsened with heavy chewing, visiting the dentist, among other activities. This is a very common presentation. And, for this person, they oftentimes would, want to see that there's a change in their clicking. But what you'll see with your assessment is, what's the functional, like limitations? What are the impairments that are contributing potentially towards that clicking? Because at this point, are we going to be able to really make a change in the structure of whatever was impacted 5 years ago? Probably not. But what we can change is if this person has a large deviation. So let's say I didn't say specifically what side it was. So if we say this was on the left side, if the patient opens and they have a large deviation towards the right, and as you watch them move, you see that they are frequently biasing their right side. And then as you palpate, you find that they have increased muscle tension on the right side. What I've noticed in my practice is, that left side, because it's frequently, anteriorly gliding, it's frequently moving more than the right, is being overworked. So by addressing the contributing components that are causing the jaw to deviate towards the right, we can restore normal, more symmetrical motion on the left side. Theoretically, literally deloading that side, and now you're putting less stress on it. And as people go open and close, the disc kind of hangs out in a healthier spot. And I find with this type of treatment that we do see a significant change in the clicking and popping and also the symptoms. So I would say like a real good rule of thumb with someone who has a disc displacement, particularly one that is relocating or reducing, that you focus in on symmetry of movement. And if you notice that there's like an S deviation, you're trying to restore neutrality. If you notice that there is a C deviation, you want to try and figure out why, which could be muscle tightness, but it can also just be a motor control pattern, and then address that. The folks that present with like hypermobility, which we have a fair amount of folks who have EDS in my clinics, oftentimes we'll have these large deviations as well. And it's not because there's necessarily, a joint restriction, but it's oftentimes a motor pattern. Perhaps it was learned as a result of dealing with this intensive dental operation, having severe pain. They just offloaded that side and they just learned how to do that. So as you dive into it, you can kind of put two and two together, and oftentimes just trying to restore symmetry is going to be really effective. I had this patient actually last week. So this is straight out from our good friend Scribe, 37-year-old male who presented with jaw fatigue and TMJ related symptoms that functionally limit his ability to speak during severe episodes. The condition originated in childhood when his sister punched him in the jaw, which he stated caused the dislocation. I can't necessarily say whether or not it was a true dislocation, but following the injury, he reports his jaw would go out of place about once a year, and then it gradually increased in frequency, up to the point where it'd be twice a month, eventually weekly, making it progressively harder to talk. He's been undergoing trigger point injections, as well as I believe he's had some Botox, so he's currently in a relatively good spot. It's to the point where he says it's binary. I either have pain or I don't. He also has atypical facial pain, which he's seen a number of doctors, ENTs, and neurologists about. So he gets this kind of constant dental drill-like pain in his teeth. It's very interesting. So, you read this, right? And you might say, oh my God, where do I start? What do I do? But when I watched this guy move, and as he was talking to me, he had this, like severe bias to the right. Like as he would talk, his jaw would just consistently move from right to left. And when he opened, he just shot straight over to the right. Upon palpation, he had, severe increased masseter density on the right side, very palpable, easily palpable taut bands. I was able to reproduce referred symptoms with deep palpation to the masseter, the temporalis. So even though it sounds super complicated, it is actually pretty straightforward. We're going to work on restoring symmetry. We're going to address the muscular dysfunction. We're also going to dive into sleep because he's got some, funky sleep habits. And then posturally, he's got pretty bad posture. So even though this sounds kind of crazy and this type of patient that I think, sometimes my staff would come to me and be like, oh my God, what do I do? At the end of the day, it's fairly straightforward. Restore symmetry, address the muscular dysfunction, and you're going to see some progress. Whether or not I can make a massive change in his symptoms, I'm not quite sure. But I know that there's, significant progress to be made. And, when I talked to him, I said that. I said, you know, you're currently not in a flare. And I don't know, based on, I just don't know how much progress we'll be able to make. But what I can tell you is that I see that there's abnormal motion here. I can see that there's modifiable, impairments that we can definitely treat. And as we work on those, we'll see improvement. And as I've worked with him for a couple of sessions, what I've realized is that underneath the deviation, underneath the muscle tightness, he's really weak. Doing 3 sets of 10 of 3 different motor control exercises fatigued his jaw to the point where he was like, I can't do anything else. Like, I'm done for the day. And that really opened my eyes to what his load tolerance is. And also, from a prognosis standpoint, made me feel very confident that, even if I just gave him the jaw exercises, he's going to see progress. But then when I add in addressing the impairments of, abnormal motion and asymmetry, there's a lot that we can do. So long story short, here's some of my sources. As you like walk away from this presentation, sharing here for a second, I recommend thinking of the jaw from a simplistic standpoint. You've got your different diagnosis classification categories. Is it a muscle-based presentation? Is it more of a disc displacement presentation? And then from there, like, is it acute or not acute? And then, less frequently, there might be an arthritic presentation. You kind of have those 3 diagnoses, and then from there, dive into the impairments. Try and put 2 and 2 together. Work on restoring symmetry, address muscular dysfunction, be mindful of sleep and posture and daily habits. And there are things there that we can change with our hands and with exercise. And there are things there that we need to help our patients change. The things that they're doing outside of the clinic, those are going to be very impactful. So having strong conversations about that is going to go a long distance. But we do that every day with all of our patients. So you should feel confident treating a jaw pain patient based off of, even just a basic understanding of these different classifications. So with that, I'll open up the floor to any questions. If anybody has one, please feel free to, raise a hand or unmute or pop something in the chat.
Excellent. Thank you so much, Ben. That was an excellent presentation. And again, a very important topic that you'll run into, and some of the modifiable hints you were giving are valuable for the patients. So I'll lead off the questioning. So yawning and large bites. You can tell people take small bites, don't yawn so much, but do you give them any strategies so that they can become more aware of it? Because sometimes they're not aware of it till after they do it. So what strategies do you give patients?
Yeah, that's a good question. I'm glad you brought that up because I didn't talk about it. So understanding the resting position of the jaw is usually where I'll go with that when a patient's asking about these larger movements, so they can get an idea of where they should be spending the majority of their time and then how they move away from it. So at rest, if we're not talking, if we're just like working on our computer or hanging out, our tongue should be on the roof of our mouth, like our palate just behind our teeth. We should have about about a centimeter space between our teeth and be breathing through our nose. As we go to open further, if someone has a painful click, I'll often, give them the cue of keeping your tongue on the roof of your mouth in these moments. So if you do need to yawn, hold your tongue on the roof of your mouth and try and like resist the yawn. I find that can be helpful. For taking large bites, usually it's cues associated with just like cutting up the food. In some cases, you just have to avoid, like the big sandwich or a bagel. And I think people are usually understanding of that.
Excellent. Thank you. Did you see some of the questions in the chat?
No, let me pull that up. Joseph, yeah. So he has a pretty large C curve. So when he's talking, he's kind of like constantly going like that. Excuse me, I'm exaggerating a little bit. And then as he opens, it goes more like this, actually. No, it works all right. Scott, I appreciate that. Um, Laura, so for exercises, I can walk you through them right now, actually. So I'll usually in the clinic I have a vanity mirror, like a good old fashioned like makeup mirror, handheld, and I'll give it to the patient. I'll walk them through, starting out with opening and closing, and we'll usually already have talked about the fact that there's deviation. Sometimes I might not necessarily bring it up right away. I might say, yeah, like there's an asymmetry of motion, and then I'll have them open and close and be like, what do you see? Kind of depending on the specifics of the the amount of buy-in I have from the patient, or how profound I want to open up their eyes to it. But you'll have the mirror in front. A phone like on selfie mode can work as well. A mirror in their bathroom, and we're starting in the midline. So I'll tell people to smile, and then you want to find that midway point. Sometimes the like alignment of the jaw isn't perfect. Sorry, the alignment of their teeth isn't perfect. So you'll need to cue them on finding that midpoint. So it could be like center of the nose into the chin. So like for me, my teeth like to rest a little bit over to the right. So I'm going to come back to the middle. And then from there, I'm going to open, with my tongue on the roof of my mouth, about a centimeter or two, and then close. And then to progress the exercise, you work on opening more and more. I used to really focus on the tongue on the roof of the mouth. Now I'll just say like the first 25%. And I'll cue them on how much, okay, like, that was perfect, just a little bit, kind of watching for more of that spinning, less of that glide. As I progress and as I see that they're improving, I'll work towards 50%, 75, and then kind of moving all the way open and close. There is a version of the exercise where you have the tongue on the roof of the mouth. You open about halfway, tongue comes down, then open the rest of the way, and then close. I used to do that, but I found that it just gets confusing. Patients are doing all sorts of funky things with their tongue. So I just like to simplify it. It usually takes people about 2 weeks, unless there's a true limitation, like if someone truly has a joint dysfunction or a really, really, really tight, like shortened masseter, it might take longer. But for those who have a motor control impairment at baseline, oftentimes over the course of 2 weeks of working on just that opening and closing, they can get a really good idea of the control, and start to present with better opening and closing. The next one is lateral deviation. So same thing, starting here, opening maybe just a little bit, and then going over. So going over to the side, back to the middle, other side, back to the middle. You might want to do just one side at a time. Kind of depends on what you feel is most important. With that same thing, I'll start with a little bit of opening, a little bit more opening, working almost towards full opening. But the important thing to know is that when you're fully open, you don't have a ton of lateral motion. So really like the beginning and mid-range is when you're going to be able to retrain the control the most. Also do protrusion and retraction forwards and backwards. People who have a significant stiffness sometimes will really like dive over towards the side that's tight. You can also do isometrics and resisted, like full range of motion exercises. I don't do those as frequently. I'm seeing more of the masticatory and muscle pain patients. Usually they're already so overworked. But I have had a couple of patients who presented postoperatively, or were atrophy from Botox, or there was an asymmetry that I would work on, specifically engaging on one side and then working through the range with control and opening, closing. Terry, this is something we should create, a gum that's kind of like a Theraputty that has different densities, and patients chew it to strengthen their jaw.
There we go. I like that.
I've had that idea for a long time, but I'm not an engineer. So you can think intuitively. Like if you feel that the patient is really weak, and you test it and they have no strength on the right versus the left, just give them resisted exercises and then progress it as you naturally would, which using manual pressure from their hand. We can create a lot of force with our hand, and repetition there is going to be really helpful. Sleeping positions recommend patients avoid because of added load to the jaw. I find that people who have a hypermobility or an instability will often complain of discomfort one side versus the other. I get that myself. If I'm sleeping on my right side and my pillow is pushing my jaw towards the left, it feels like it wants to come out of place. So with folks who present with that type of complaint, sleeping on their back is really important. People who have like a bias towards one side, and it's not a hypermobility or an instability, but they clench more on one side, if they're turned a certain way, like that may contribute. I don't necessarily say, I can't really say there's like a best sleeping position besides just being on your back and being well supported by a pillow. Um, that's something that, sleep test might help out with. If someone's having a lot of trouble sleeping, they might find that they wake more frequently when they roll onto their right side, or if they have an apnea. So what I didn't necessarily get to talk about is the impact of gravity when we're on our back. Pulls our tongue and all of the muscles in our mouth backwards, and it also pulls our mandible backwards. So if someone has a really hard time getting into deep sleep, you could rationalize that perhaps they might be better off, assuming that their sleep hygiene wasn't the contributing component, maybe sleeping on their side to help reduce the gravitational pull of their jaw posteriorly. Do you avoid activities range of motion in which the pain with clicking occurs? Does the clicking usually continue as treatment progresses throughout the week? It depends for Lindsay. It depends on the presentation. If it's painful clicking, then and we can't change the symptoms by modifying their movement, in the sense that if they're deviating to one side, and if I cue them to stay more in the midline, if their symptoms improve, then I might say, okay, like really focus on staying in the midline as you're opening all the way, because that feels better. But if they can't necessarily do that for whatever reason, then I might recommend that they don't open fully, and change up their movement patterns. I think what's more important is usually chewing and being mindful of which side to chew on if they're acutely inflamed, and then also like modifying the foods that they're eating. I've usually with treatment, clicking will change. The frequency is usually the thing that I'll see the most. With that being said, sometimes it increases early on, particularly if someone has limited motion. As you intervene and they start to gain movement, they're now gliding forward more and causing that disc to move more. So if a patient after a couple of weeks is like, my jaw's feeling better but it's clicking more, then don't sit back and think that you're doing something wrong. You can think through the mechanics of it, and it can oftentimes make sense. It can also There can also be a wolf in sheep's clothing, so to speak, as it relates to hypermobility, where people present with perhaps a deviation and a lot of tightness, but then as you loosen up the muscles, as the tone changes, you now are watching them move, and you're like, wow, you're actually hypermobile. You've got a crazy amount of motion, and perhaps that was a contributing component. So I'll kind of go based off of instinct. You kind of have to trust your gut on whether or not you feel like the clicking is pathological or problematic, and then recommend a change based on that. Scott, that's a good question, actually. And I don't know if you've met this patient. So Scott works in Central Square. I have a patient who was born with a congenital deformity. His frontal bones were underdeveloped. So he had to undergo a ton of surgeries to like redesign his face, so to speak. And he has used like a jaw strengthener, but he's really the only person that I've recommended that for, just because a lot of my patients don't necessarily present with weakness as often with closing. However, I about a year ago had a patient who was post-op, and she needed strengthening. So we talked about different ways that she could work on building strength back in her masticatory muscles.
Excellent. Well, I think I want to be respectful of people's time. I do have one more question before we finish, and that's just my own, and it's just for our colleagues who work in states that they might not be able to dry needle. So for like lateral pterygoid and that, are there other strategies that just take longer for retraining that as far as myofascial treatment is concerned, just for those who might be limited by their Practice Act?
Yeah, that's a good question. I don't know, honestly, Terry. I'd almost punt it back to you, because in my training with myopain, we talked a lot about whether or not you can truly palpate the lateral pterygoid, and really the big takeaway from their work that they've done with cadaver, like needling, which is pretty cool. They go out to a clinic in Colorado and they actually like needle cadavers and they dissect around it. they don't believe that you can really palpate the lateral pterygoid enough to massage it. And I know a lot of people will get in the mouth, on the inner aspect of the mandible. I don't utilize that technique that often. I've had people say they've had it done and it can be helpful. And I know some groups, still teach it. So from my experience, I would struggle, honestly, if I couldn't do dry needling to target that. But with that being said, there's so much change that you can make by addressing other muscles, but then also with motor control training that I believe will have a change over the course of time. So it might not be as impactful in the moment, but if you're addressing the things that we talked about, I believe that you would see a change in the impact of that muscle's dysfunction.
Yeah, that's kind of my takeaway for that too. Just that if you do work on those other things, that it's just all part of a neurological set that will calm down. So it takes longer, but
Mm-hmm.
it's not necessarily impossible because
Yeah.
and they've been struggling for a while. So those modifiable things work well in tandem with some of the other techniques they can do. So,
Mm-hmm.
well,
Yeah.
Ben, thank you so much for this presentation and taking the time. And for those of you who work inside our organization, you have questions about TMD, he'd be more than happy to. I'm speaking for him, but I know that he would be more than happy to field some of those questions because they are an important group that sometimes gets over applianced and
Mm-hmm.
undertreated in some ways. So I want to thank you again for your dedication and time. And for those of you outside of our organization, we do these presentations. Try to do them monthly, except around holidays and everything. So our next one is going to be on rowers, but this is just our way to try to see if we can advance knowledge in these less treated areas. So I don't know if you
Yeah.
have any other comments, Ben, before we wrap up.
Last thing I would say is
Yeah.
if you're not feeling super confident with treating the jaw, just try it out. A patient who mentions that they have tightness or they a little bit of pain here, like when they just throw it out there, just kind of take a quick assessment, start to recommend some soft tissue work for them, just kind of play around with it. These people go through years and years without treatment. It really is crazy how often they get just thrown into the world of dental TMJ specialty, and they spend a ton of money, and they have these interventions that are sometimes impactful. But for the folks that get to us, oftentimes we could have intervened earlier. So if you hear it, don't just say, "Oh, I don't do that." Try it out and reach out to me, Terry. If you have any questions. At the very least, we can help instill some confidence and walk you through the process, and you'll feel really good about yourself when you help someone who is dealing with the type of pain that these folks oftentimes deal with.
Excellent. Well, thank you so much. That's a great conclusion. So thank you so much for your time. Everyone have a good evening, and this is recorded for those of you who want to review it again. And thank you again, and we'll see you at the next one.
Thank you, Terry.
Okay, thank you.